Dumelang. Ka leina la ka ke nna member Mabala, ke serva mo committee ya health. Ke a leboga.
Dumelang, Sanbonani, he banna. Kokosi le teng mo. Jwanong a le sa dumele tje. Okay, nna ka lebitso ke MEC Nomathemba Mokgethi. Ke tswa gone mo Kokosi mo. Ke a leboga.
Okay.
Oh, dumelang magolo. Nna ka lebitso ke nna Tumelo Molatlegi, ward councillor ya ward 24 in this ward. Thank you. Thank you.
Dumelang, ka lebitso ke Khanala Mazaneng, ke tswa Department of Health, ke acting chief risk officer. Ke a leboha. Thank you, Nokwazi.
Ralocha, ke nurse Konjiwe Masilela, ke tswa ko Department of Health, ke director for maternal child health and nutrition. Ke a leboha.
Sanbonani, igama lami unokwazi ngidinga support portfolio committee ye health ngiyabonga.
Okay, there's other members of the department here. Maybe what we can do, my name is Petros Mabunda, a member of the health committee. Maybe what we can do, we can just by show of hands or standing up so that Van Born, members of the department. And I'm informed that we also have CEOs of hospitals. Carltonville, Yusuf Dadu, and Leratong, the CEOs, can you stand up so they see you? Oh, this is our leadership. No, thank you. This is a follow-up session to the one we had on the 21st of May. Which at that session we agreed that there will be a follow-up, which today is that follow-up. There were issues raised, there were recommendations for the department to look into. They will respond as part of this session. But before we go on, can I allow the ward councillor of Ward 24, Councillor Mlatlegi, to welcome us?
Khotsa bele lena. Kurola ke bena yini. Nda. Huwe more. All right, no, thank you very much, leadership that is here. I'm sorry. Let me welcome all leadership that is here, political leadership, all various stakeholders. You are more than welcome in this ward. I'm feeling much imperative to be here because when you are surrounded by leadership, you must know that you are blessed. Ona le ko shengwe re ibina nkosi yone ba re amogela baeti le tla fumana mahlonolo. Now you must know that whatever that is going to be presented also, it's a moral anguish during hospitalization and illegal abortion. It is much imperative for us to grasp that. Let us not undermine this. Remember, knowledge is power. Education is a key one can use to change the world. It's an ornament of refugee to adversity. It's a precondition for development. Now, whatever that is going to be presented here, never, ever undermine that. Ka mantswe a reng yala, I'll be concise to the point. Thank you very much. Ka re Modimo a thabasiona ka lehlohonolo fatshe, ha Modimo a le teng a gona mathata. Joko ya hao e bobebe. Joko ya hao e bobebe. Venkatulula tumelo na kitebe, tumelo na kitebe, enkampembisa yakaloki fumani, yakaloki fumani, elanyawu irauna likalandia, irauna dikalandia, all right, no, thank you very much. Ha Modimo a le teng a gona mathata. Amen.
Thank you, Pastor. Thank you, Councillor. Thank you. Before we go, I will want to extend the apologies that we received for the meeting today. The chairperson of the committee, Dr. Tikhamela, is unable to attend. Member Bloom, Member Duplessis, and the HOD of the department is on sick leave. They were supposed to be part of the meeting. Nokwazi, can you go through the background?
Thank you, Chair. Just briefly regarding the background, the stakeholder session on moral anguish during hospitalization and illegal abortions took place on the 21st of May 2021. The causes of moral anguish were presented and were named as mental well-being and health, being the lack of services for mental health since employees work in a high-pressured and stressful environment. The department's occupational health wellness program did not reach all employees and was found to be ineffective. The staff feel unsafe at work since in most situations, security is only provided for entrance to the facility and not for staff protection. They raised lack of career development and career progression with no opportunities for upward mobility. Staff communication protocols were not clear. And they were requested to review and modify them. There were shortages of equipment and tools of trade, and that these needed to be rethought of, and there was dissatisfaction with compensation levels and other perks and recognition, unclear policies and rules, and a burden of administrative paperwork that impacts key services. And there was a topic that was discussed on how the department can fix the moral pain that the healthcare workers are experiencing. There were a number of initiatives that the department had come up with, including the EVP program, the child care facilities at institutions, the burnout and resilience program for staff. Also, there was a GPG, psychosocial services, the Zinagegele, which was there to solve related services that would be available digitally over the phone. Also, the department was going to launch initiatives such as staff recognition awards, choir competitions, etc. And then there were plans that were discussed on how the illegal use of termination of pregnancy services can be kept. Also, it was stated that before delivering the service, all nurses have to undergo and finish the necessary training. The private healthcare providers, such as nurses and physicians, were urged to apply for designation. The department also performs site inspections of these services in accordance with the Choice of Termination of Pregnancy Act. When a nurse is also accused of providing unlaw TOP services while working for a department, an investigation is launched, and when found guilty of a misbehavior, they face disciplinary procedures. Also, there's collaboration between the department and SAPS to bring offenders to justice. And then these were the Portfolio Committee's recommendations that in order to prevent pregnancies from being terminated illegally, the department should work to increase the number of second trimester institutions that offer top services. To have more access to resources, the department should create partnerships and relationships with private and public sector. Since customers won't switch to another method of contraception, the department needs to develop strategies to deal with the shortage of contraceptives. And then to maintain excellent communication, there has to be collaboration amongst committees within the department, such as HIV, IPC, OHS, etc. This will also prevent litigations. The department should also intensify its public awareness initiatives about the resources and services available for free abortion. And then lastly, the department to present and update reports on efforts to implement wellness program for all its employees. Thanks, Chair.
Thank you. That was what came out of that first session. We'll therefore allow the department to present their side. MEC.
Thank you very much, Chair. I think the department is under the leadership of Ms. Mupe. So I will ask Ms. Mupe to indicate who is going to do the presentation. Ms. Mupe? Through you.
Good morning, MEC, and to honorable members of the Portfolio Committee on Health and all participants in this meeting. The department will respond to the recommendations made by the Portfolio Committee on Health. The person responsible for this presentation is Mr. Skonjiwe Masilela. He's the program manager for this very topic that we're going to talk about. He's already on the stage. He has the presentation. Thanks.
Thank you, Chairperson. I will start the presentation. The purpose of the presentation is to respond to the recommendations of the roundtable discussion conducted by the Portfolio Committee on Health regarding the moral anguish during hospitalization and illegal abortions. Introduction. The Portfolio Committee of Health conducted a stakeholder engagement with the Gauteng Department of Health on the 21st of May 2021 at the Silver Star Hotel and Casino in Pine Haven, that is Krugersdorp. Purpose of the engagement was to present, one, the cause of the moral anguish the healthcare workers face, plans to curb the perpetual use of illegal termination of pregnancy services amongst looking at the healthcare workers, and stakeholder engagement of the Health Portfolio Committee looking at medical malpractice and litigation. In attendance were the community members and private providers of termination of pregnancies. Following the stakeholder engagement, the Portfolio Committee made the following 6 recommendations I think that the department needs to implement. The increase of second trimester facility that are providing termination of pregnancy services so as to avoid illegal, illegal termination of pregnancy services. The collaboration or partnership with private public service providers, so needing that we should have this partnership as government service providers and the private providers. The plan to address the lack of supply of contraceptives since clients refuse to move to another form of contraceptions. The strengthening of the campaign to create awareness around facilities and services offering termination of pregnancies for free in the province. The progress report on plans to roll out wellness program for all staff. This presentation then provides a response to the recommendation as stated above. Background: the termination of pregnancy services in the province is mandated by the Choice on Termination of Pregnancy Amendment Act number 1 of 2008. It has already been amended twice, the Act. The principal act is Choice on Termination of Pregnancy, Act 92 of 1996. Now the Act highlights the two areas as amended. Designation by the MEC, and all private providers will apply and then be designated by the MEC. That nurses will be trained, both nurses and midwives. Initially, it was only midwives. Currently, Gauteng Department of Health provides termination of pregnancies in 30 healthcare facilities as follows. We've got community health centers, which are 14. In the 14 community health centers, we provide first trimester termination of pregnancy, which is below 10 weeks. District hospitals, we provide first trimester and second trimester. Regional hospitals, we provide in one. Leradong is providing second trimester up to 16 weeks. Yusuf Dadu, which is a district hospital, and Carltonville are providing first trimester, which is below or 12 weeks and below. Then you have Rentgate in clinic in Randfontein is providing first trimester. Tertiary hospitals, we've got only 2 of those in the province that are dealing with maternal issues, maternal and women's health issues. That is Tembisa and Kalafong. National Central Hospitals, there are 2 that are providing Krisani Paragonat Academic Hospital and Dr. George Mukari Academic Hospital. Presently, I think I've gone through this. Presently, there are 5 that are providing a second trimester. When we presented on the 21st of May 2021, we had only 3 of these facilities. Now, we have designated private clinics per district, now per district in each of these districts. I will start with this district. In West Rand, we have only 2 private providers. In Eguruleni, we've got 8. Johannesburg, we've got 12. Sidibeng, we've got 4. Tshwane, we also have 12. The increase of second trimester facilities that provide termination of pregnancy to avoid illegal termination of pregnancies. The department has increased the number. I've already indicated that from 3 to 5. So I've already indicated which hospitals are providing. I will repeat: Krisani Paragonat Academic Hospital, which is in Soweto; Dr. George Mukari Academic Hospital, which is in Harangua; Leradong Regional Hospital, which is in Kagiso; Heidelberg District Hospital, which is in Heidelberg, listed around there; Jubilee District Hospital, which is in Hammanskraal. The collaboration or partnership with private providers. The department does not have specific public-private partnerships. Now, specific in the sense that we say this is the only partner. Private providers are encouraged to seek designation by the MEC for health to provide termination of pregnancy services. The following are the private providers that have been designated by the MEC to provide termination of pregnancy services. It's a long list, I'll try to go through it. Alphin Building, Pretoria Central, Dr. K.G. Leslie Medical Practice, Rem Square Facility Practice, though we did not put that according to, as I've said, we only have 2 here in the district. Green Cross Clinic, Tshwane Women's Clinic, there are 3 of those in Tshwane under the same name. Maristop Group, South Africa, we have 6 of them, and 3 of them are providing second trimester. Mayor's Place Medical Center, Matladi Consulting Women's Clinic, His and Hers Clinic, the 2 of those clinics, Binoni Healthcare, JJM Health Services, Dr. Mbule Women's Clinic, BBM Reproductive Health Services, Dr. Alfred Fabi, there are 2 of those, and those are the ones that are here in the West Rand. Maria Sefiri, Keto Healthcare, Dr. Ajay Family Practice, Tutoy Street Medical, Prop Top Women's Clinic, there are 2 of those. Boy Papalo Women's Clinic, Women's Wellness Clinic, Rosen Health Clinic, The Rock Health Clinic, Val Women's Choice Clinic, Kathy Women's Clinic. In the Val, we've got around 3 of these clinics which are owned by the same person or the same doctor. Plan to address the lack of supply of contraceptives since the clients refuse to move to another form of contraception. The contraception and fertility planning procurement processes are managed as a transversal contract at national. So national will issue a tender for all the contraceptives, and the department will participate on the tender as the rest of the other provinces. Suppliers fail to meet their contractual obligation due to either the lack of active ingredients or in other cases, suppliers just stopped. Now, during COVID, we note that suppliers stopped focusing on contraceptive, so especially the injectables, your Depo-Provera and Neisterate. So they moved to focus on COVID-19 vaccine, especially Pfizer. You remember that Pfizer is the one that is providing us with Depo-Provera. And then Bayer is providing the department with Neisterate. The department participated in the contract to mitigate the challenges experienced by the National Department of Health. There's a new contract where new methods have been introduced. Currently, the department has introduced Mirena, meaning the National Department of Health, with the participation of the province. We have Mirena. Mirena is your intrauterine contraceptive device, which is similar to Copper T, IUD, but now Copper T is no longer going to be used as a method of contraception, but it will be used as a method of post-coital, the morning after method. But the department has also introduced now recently the patch. Those women who don't want to take the other available methods, they will have a patch now, a skin patch that will it will act as a contraceptive. Then also we have vaginal rings. We have introduced vaginal rings as a way of expanding the method mix. In order to increase access to contraceptive and other related sexual reproductive health, we have the department has engaged private providers, nurses and doctors, and tomorrow we will be having close to 100 of these providers discussing the service level agreement on how they can be part of the production. Future plans, proposed target per hospital. Now, these are future plans that the department is looking at. Second trimester is that in each district hospital, at least each of the district hospitals in the province must have at least one bed for second trimester. The National Central Hospital must have at least 4 beds. Now, termination of pregnancy services in all public hospitals with the focus on provision of second trimester. When we reviewed all of that, the one district hospital I'm talking to, it's Heidelberg, that has got 1 bed. And at the moment, we've got 4 beds at Krisani that are for second trimester. So the way the department is looking at it is that as a way of moving forward or bringing to fruition the plan is that 2 district hospitals, in this case here, you've got 2 district hospitals, so it means we'll have to have 4 beds from the district hospitals that are here. 2 in Carltonville, 2 in Yusuf Dadu for second trimester. And then currently, Lerato will have to increase the bed to 6, so that we have 6 beds. Then the central hospitals we don't have here, but then we have 4 of them. All the 4 and plus 2, which is the 2 tertiary, will have then to have 4 beds, so that we can increase the number of second trimester beds. And as I've mentioned, also we have designated 3 facilities that are private, that are providing. But in this case, the department should be providing for the public in the province. So we also propose options that need to be looked at by these facilities if they cannot meet the requirement that we have put forward. Is that hospitals, we've got 3 options that we are proposing. Hospitals must provide the service, whether they source it out or get one, employ using the same staff that is currently available in the department must provide the service. And should the staff then refuse to provide the service, then they should then sign a register on conscientious objection saying why they don't want to do the service. Hospital should employ a sectional doctor. Now in Krisani, they've used the first option where they've got staff who are rotating throughout the unit. Dr. George Mukari, they've employed a sectional doctor who comes whenever there are referrals and then they will come to hospital. Or they should outsource the service. Now they can get another private provider who will provide the service. And then the hospital, in that case, will have to pay that private provider. Strengthening of campaign to create awareness around facilities and services offering termination of pregnancy in the province. What has happened on the 29th of August, Eguruleni, where the MEC and the DM, Deputy Minister at National, had a huge successful campaign where they going around targeted street in Jimiston and clean the posters or the walls where these posters were posted by the people who are providing illegal abortion. So there was that clean-up session and the walkabout, and after that there was a big question and answer session with the community around Eguruleni. Then in the next 2 weeks, there will be one in, next week there's one in Johannesburg on the 15th, and then in Tshwane, there's a similar awareness campaign on the 20th. Now the province has got media platforms that are used. There's a www website that is gauteng.gov.za. There's also Gauteng Provincial Health Department Facebook. There's also Twitter at Gauteng Health. There's also Impilo app, which is free. I think the community can access that. We also have, as a department, radio slots where we discuss all these issues of sexual and reproductive health and rights of women and communities to access services, or whether a termination of pregnancy and other services. Ensuring collaborated committees, the HIV, IPC and OHS for active communication to prevent litigation. The branch corporate services is establishing a joint committee made up of legal services, HR, OHS and wellness, healthcare quality management, nursing education, nursing practice, ICT, and communication to prevent litigation. Medical litigation will thus be addressed through legal means, mediation, litigation, etc., and support functions that are looking at workload, shift and leave management, HR processes of recruitment of the right number of employees using norms and standards, training and development, ICT, OHS and wellness. All of this will support the reduction in litigation. The department has an IPC committee where HR and OHS participate and address related IPC risk issues. Then this also talks to surveillance and prevention measures and control of infection. 29 employees have been trained on fundamentals of IPC. More will be trained on IPC at the postgraduate diploma level. The progress report on plans to roll out wellness program for all staff. The Gauteng Department of Health has consulted organized labor to approve the CRQ management policy in November 2020. They also established committees or OHS committee in all hospitals and is sustaining their functionality annually. It is currently updated for signing by the current HOD, so the policy is the one that is currently awaiting the signature. This policy will assist with the identification of hazard and management of the occupational risk for injuries associated with employees, rendering termination of pregnancy and all other employees. So it cut across. 3 other policies were consulted on and are currently due for signing also by the HOD. HIV and AIDS and TB management, which incorporate COVID-19 in the workplace, health and productivity management policy, wellness management policy, employees rendering termination of pregnancy and all other services will benefit from the 39.3 million, which was successfully mobilized from the Premier's Budget Committee to appoint occupational health practitioners and specialists to advise management and workers. And that will also talk to provide supervision of OHS programs in Gauteng Department of Health. These include lay counselors, clinical and industrial psychologists, safety engineers, OHS in consultation agent, that is OHS in construction agent, occupational health nurse practitioners, occupational medical practitioners and occupational medical specialists. They also talk to exposed scientists on occupational hygienists. Posts are currently created and will be filled in 2020 in the financial year 2022-23. The appointment of these practitioners and specialists will increase internal capacity to have workers provided with internally Gauteng Department of Health, OHS and wellness centers, as opposed to the Zinagelele program, which was wholly outsourced but had only 6% utilization. The progress report on plans to roll out wellness program for all staff continues. Employees rendering termination of pregnancy and other services will also benefit from the services of currently employed OS practitioner trained in exposed science. There are 50 of them by University of Wits, and then ergonomics 50 by Rhodes University. This will identify occupational hazards, assess the risk of occupational injury and disease, advise on necessary control and preventive measures. The Gauteng Department of Health has policy position through the MEC's budget speech 21 to 23, 2021 to 23, to get 4 central hospitals certified to be in conformity to international standard on occupational health and safety, which is ISO 45001 of 2018. Environmental management ISO 14001 of 2015, and quality management 9001 of 2015. This will improve the public image of Gauteng Department of Health and improve trust that workers have in Department of Health as employees, and have Gauteng Department respond better to the moral anguish of all employees, all of them, including the ones that are providing termination of pregnancy in particular. The EVP program still exists and is running with EVP champions in different Gauteng Department of Health facilities. It has been integrated into the wellness program to raise employee morale through facility-based events. Special Kanyisa Awards are planned for December 2022 this year as part of the 6-month plan to recognize the exceptional work and contribution of Gauteng Department of Health employees. Continuing with the progress, responding to the rollout of wellness program, the lay counselors, clinical, industrial psychologists, occupational health nurses, and medical practitioners, specialists who will be appointed in financial year will scale up the burnout and resilience program to staff beyond the 50 occupational health practitioners trained on the management of burnout in the past financial year. The moral injury will also be addressed through the values clarification training and scale up of integrated management of psychosocial stressors in the workplace. This will be done by the same lay counselors, clinical industrial psychologists, occupational nurse and medical practitioners, and other specialists. These are psychosocial stressors that will be addressed. The stress, the alcohol, the violence, the HIV will be addressed looking at physical activities, nutrition, economic distress, empowering issues of how to manage budget, healthy sleeping, address issues of tobacco addiction. This will be in line with solve as defined by the ILO, I think the International Labour Organization. Recommendation that the Portfolio Committee on Health note the Department of Health's response to the recommendations of the roundtable discussions regarding the moral anguish during hospitalization and illegal abortion. Thank you.
Thank you. There is the response from the department. We can have now a discussion starting with the committee member, Honorable Mabala.
Ke a leboga modulasetulo. Re lebogele le yona presentation from the Department of Health. Ke nagana gore mo presentation ya lona ra and some of the things tse re kopang now and again gore ha le use the abbreviation le refer maybe in full, because now ne le bua ka bo di EVP, not everyone understand gore EVP ke eng, including myself. So ne re ka lebogela le gore in future re kopa gore le tlatse maina ka botlalo gore setšhaba se kgone gore se tlhaloganye gore sentle sentle le bua ka eng. E re ke raise gape le taba ya that private and public partnership gore le di buile re di utlwile, mara ne go ka nna botoka if ne le buile gore di ko kae, maybe le provide le di contact details so that batho ba ba tlo di needang ba itse gore ba ya kae. I think sena se ka thusa in terms ya gore o kry bomme ba nna le bana ba tlogela bana. That's why nako re kry masia a silwe fela mo sebakabakeng. I think it's because bomme ba ne leng gore ne ba sa batle that pregnancy, ba feleletsa ba sa itse gore ba ye kae, mo eleng gore ba fetsa time ya bona and then ba fetsa go pepa ba feleletsa leng gore ba latlhile bana. I think it tlo nna botoka if re ka isa information ko di clinic, because ba gaetso setšhaba sa rona ba na le access to the clinics. So it tlo nna botlhokwa thata gore maybe le shebisise gantle as Department of Health gore batho ba kgone go nna le information so that re kgone gore re decrease this number ya abandoned babies. I think ke tla fella mo gone jaanong. Ke a leboga Chair.
Okay, thank you. Jabu Sizwe, I understand he wants to respond first before we open it to everybody.
Let me take this opportunity and time to reintroduce myself. My name is Jabulane. My surname is Wana. Jabue Sizwe is a topic for another day. I am a motivational speaker and community developer from Carltonville in Kuzo. So, with all due respect, can I request that we stand up on our feet, all of us, except from the honorable speakers. Right. I'm going to be very short. I'm going to just be giving a word of encouragement. So what I want to do is that, or what I want to highlight is that there's a song that we sing that says, "Hotla ba jwang ha ke siya ko bo ena ebola." How will it be like when I leave this world or this body, this immortal body? So now the question that I'm asking It's a question that each and every one of us must ask themselves a question that when you leave this world, what is it that you would have left for the next coming generation? Because remember, I usually tell people that the real education is our attitude and behavior towards others. Why? Because it defines our entire past, remains forever. We remember Nelson Mandela, we remember Solomon Kalushi Mahlangu, not because of what they've done for themselves, but what they've done for us is still remaining even namhlanje. So now ask yourself that whenever you leave this world, how will it be like? Will there be an individual that says, I am somebody in the society because of that woman? Let us stand in the gap and let us stop judging each other. Therefore, let us start building each other, because I believe in building one another. We need each other. Ngiyakudinga, uyangidinga. As there's an African proverb that says, moto ke moto ka batho. So now, when I'm going to close, I would love you to say these 3 words after me. And when you say them, I need you to have emotions, because these words already bui fela, and already bua the emotions they are there, body facial expressions and stuff. I need you to say, wow, wow, wow. When are you going to have the wow moment of your life? When in your life are you going to look at yourself in the mirror? When in your life are you going to stand up and say, wow, I've done it very well? Let me be a bit spiritual. When you read the book of Genesis chapter 1, verse 1, it says, God, in the beginning, the earth was without form and it was formless, and God was there. Verse 3 says, there was no light. Then he said, let there be light. After the light was there, he clapped hands for himself and he said, this light is good. So now God never needed someone to say, wow, this is beautiful. He did it by himself. So now to us, this must be a lesson that we must have that wow moment after doing something that is very beautiful. You must look at yourself in a mirror and say, wow, I'm handsome. Wow, I'm beautiful, because you are reducing into a labasa blella. It's an extra one. You know, when I post a message on Facebook, I first like it kahat. When you follow Otwe like a kahat, it's an extra one. I didn't need it. So now I need you to say, ow. Ow. When are you going to have that ow moment in your life, when people are telling you that you'll never amount to anything in life because of your background? When are you going to stop complaining about, remember, life is not what happens to you. Life is what happens because of you. So when are you going to have that ow moment when people are saying you won't amount to anything in life because of your background? What I've learned about the background is that your background will do one of the 2 things in your life. It will either educate you or eradicate you. So it is up to you to take a decision on how you want your background to affect you. So when I close, I would like to say, have you have you ever seen when you are taking a dog and putting it inside the water? So there are people there are people who are going to tell you all these kind of things, but I want you to look at those people and just shake it off. There are people who are going to tell you that you think you are better than them. Just shake it off. There are people who are going to tell you that you think you can do this better than I can do it. Just shake it off. Because remember, I said life is not what happens to you. Life is what happens because of you. Thank you so much.
No, thank you. We'll just shake it off. Those that want to engage should just raise their hand. You will need to queue on the other side because there seem to be one mic available. Can we then start with this side? Can we see the hands on the right-hand side? It's one. Yes, you can go. 2, 3. Yeah, you can join the queue. At the back, so I saw somebody there. Yes, come 3. And this side, 4. Yes, you can join the queue. I can say, really motivational speaker. I don't think we will need another one. Straight to the point, not more than 3 minutes each, so that everybody has an opportunity to speak. You can go on that.
Good morning or good day. Let me call you colleagues for now, because we're here together for a mission. Let me call you colleagues for now, because we are here together for a common mission. It's risky to say, ladies and I sincerely...
Sorry, Papa. Excuse me, before Libuwali introduce them.
Thank you very much. I'm sorry. I am Khadebe, David Khadebe. I am from the faith-based organization in the AIDS Council. I am from Elders Leadership Initiative, South Africa. Let me just stop there and leave setting. When listening to this presentation, I sincerely hope that I'm observing correctly. And please, I stand to be corrected and updated. This report seems to have more to do with the staff at facilities, more than with the clients, the people who are having to do these abortions and the like. I just trust that my observation is correct. And I'm wondering, how is it that we as a community are here, harnessed together, just to look more focused, in a more focused way on the staff problem more than on the community problem in general. I sincerely hope I'm mistaken. Thank you. And by the way, I'm sorry, just by the way, colleagues from Mirafong, I'm a bit disappointed in you, just a bit. The MEC, when she introduced herself, said she is from here. And the silence was deafening. Can we just applaud our local? Can we just?
Thank you. I'm from the Val Triangle, right at Sidibeng. There's this big hospital known as Kopanong Hospital. Kopanong Hospital has shelters that can carry over 1,000 people. The same shelters were built 3 years ago. Even today, the shelters are just like that. Hadisebetse, you don't even know where has the funds gone to. I don't know whether it's Palafala or what. But the shelters are still like that. Now, when are the shelters going to be used? Because Val Triangle is very big and bigger than Soweto. The second question is, sir, you spoke about the sticking of illegal posters or flyers around of quick abortion by the culprits. What means or what are you doing to apprehend the culprits
that are putting posters or flyers all around our beautiful cities. Thank you so much.
Thank you, Mhlekazi. Good afternoon, Setjhaba sa Kokosi. Allow me, Program Director, to basically observe protocol and to say afternoon to the Health Portfolio Committee, the MEC present within our midst, the various CEOs of various institutions. Thank you so much for the opportunity. Mine ke rata ho iqalla just a little bit backward from the previous stakeholder engagement meeting. And thank you, Ntate Masilela, for the presentation. Yes, there was a call to health institutions to start opening up and provide a service at termination of pregnancy. Because babangata batho mo makeisheneng ba e leng hore we are still going the backstreet route for various reasons. Ba bangwe re re health institutions access is a problem. Ba bangwe re tshaba stigma. Ba bangwe is a lot of reasons. So now, during the presentation, Dr. Masilela, you've mentioned various institutions. And I think accidentally you left this one out. Bheke Mlangeni District Hospital. We responded to the call. Last year, it was the 21st of May, when it was said, we want all health institutions to start rendering termination of pregnancy service. We have done that. We are having more than a year now. Started at around Boma, July. So that service is actively running there. I wanted to basically highlight that. I think Ndate Francis raised a critical question that I also had. Yahore, what are we doing about the perpetrators? About these people that are performing these horrendous deeds? What are we doing about these people? The question comes back to say, we are a community. It starts with me and you. We know. The question is, are we reporting to SAPS, the South African Police Services? We must stand up as a community and say, re rata bana ba rona, re rata setjhaba sa rona, not in our name. Ha hona motho ya tla tlhokofalang mo a bolaua ke a backstreet abortion. Kapa termination of pregnancy mo setjhabeng sa Kokosi. Ha re no emela ntho eno. So it should start with us first. Remove those posters. Go and report batho ba etsang ntho tsenana tse mpe. Ke yona ntho e leng bohlokwa haholo. And then the last one, because the previous, it was a disadvantage to speak after others have spoken. It becomes a serious disadvantage. The last one, Jonathan, Quality Assurance Manager, Peggy Mlangeni. I've realized there is lack of ownership. It is high time. Makere health is one like a triangle. At the top of a triangle, you are having a client, which is a patient. At the bottom right of a triangle, you are having what we call a community. Then at the bottom left, you are having what we call the government in terms of the petrol and so forth. So the three complement each other. But it becomes an issue when you are having the person at the top, which is the patient, not taking responsibility. When you are having the community not taking ownership. The motivational speaker said, shake off things, stop blaming, let's build together. Let's take care of our health institutions. Let us play our part. Yes, we have got the right to complain, but what are we doing? Do we go there and ask, or do we wait for platforms like this, Re sa ye ho ilo lokisa, re ra re kene sepetlele, re lo botsa hore ho etsahalang, because hospitals have got what we call quality assurance officers, complaints desks di teng, kapa re emela hore re tlale tjena e beng teng mo e leng hore re a lla. We're lamenting on this platform, fella. No, I believe it is not. We shouldn't wait for a year to come and lament here. We should work each and every day. Re sebeletse dipetlele tsa rona, re sebeletse setjhaba sa rona. Ha ke lebohe hle. Thank you so much.
Good day, everyone. My name is Tandega Mngube from Atteridgeville. I'm a chairperson of Salisbury Clinic Committee. I wanted to ask the health department, why are they not stipending the clinic committees? Because they are there every day doing the job as everyone who's in the facility, overseeing the facility services. So that was my question. Thank you very much.
Good day, everybody. I'm Louise Labers, traditional health practitioner for Marathon. Okay, I'm Louise Labers, a traditional health practice from Marathon. I want to know by government, what does they do? Because to have an abortion as a lady in the backyard, you damage your body in first place. Rather to let somebody try to adopt that baby, had on a lady to go through an abortion. What happened? Because some ladies, they can manage it, some ladies can't manage it. And then this, to doing a backyard abortion or by a clinic, then there's some people, they can't handle it, then they go over to alcoholism. If somebody can answer me that question, please. Thank you.
Good afternoon. Let me take this time to greet honorable members, delegates, spiritual leaders, traditional leaders, community representatives, and the community at large. My name is Steve Clow. I'm the operational manager of Women's Clinic, the Termination of Pregnancy Clinic in Leratong Hospital. After attentively listening to the presentation, Mr. Masilela is my senior in the sexual and reproductive fraternity. I was part of the delegation in May 2021 in Silver Star, so I understand where some of these issues emanate from. I'm not going to interrogate the response or the presentation because I understand as a team player, so many efforts were put in. This is an ongoing process. Strategies are still being put in place to try and better services for the community. So I just wanted to actually highlight some of the things and actually just try and put certain recommendations or emphasize on certain points. Point number one being the issue of the moral anguish within people who are providing CTOP, that we used to have IPAS as an NGO back in the days before COVID, and later on we had CHAI, one of the NGOs that were making sure that healthcare TOP providers in Gauteng were given annual debriefing sessions. And COVID came in, and from there we never ever saw them anymore. So I just thought somewhere in the presentation I'll be able to see where did they end up and whether they were followed up or not. Secondly, the issue of second trimester termination of pregnancy. I just want to ask my seniors from the department. I'm a member of the Department of Health as well. That's why I don't interrogate and destructively criticize anything. I just want to emphasize certain things and try to ask certain things to be matter of urgency. Second trimester TOP services are a problem. So far, we are the only hospital with 2 beds for that matter, that is providing second trimester termination. I'm the manager there. I'm the one who round up the stats every month. So, guys, the issue here, lack of access to that services, it's a serious problem. I'll give you a certain example. In August alone, we had 279 patients who consulted requesting termination of pregnancy. Within 279, some were not pregnant, some were above 20 weeks, they were referred to antenatal, some they were down referred to use of Dadu and Run Gate, and TOPs that we did were 60 in August alone. Less than 16-year-olds were 5. Between 17 and 18 years were 8. 19 to 34 were 36. More than 35 years of age were 11. So I won't talk much. I just wanted to give you a little, there's a stats here. I don't want to waste time. But this is how we look at the demand. If we have 279 patients who come and consult requesting the service, it means then that we are overloaded. So the second point that I want to tap into, basically I wanted to just ask the department to try and make it a matter of agency in trying to roll out the other facilities to provide second trimester. The issue of unscrupulous providers of TOP, we're talking about these ones that we've been talking about, they put the leaflets and the phone numbers. We need to know that the root cause of this is not those people. Those people must not be blamed, because what they do is, if you are opening a car wash, you need to do a business research. Check whether your area will give you clientele or not. We, with delaying to open second trimester services and make them very much available to community, has created that. This thing is not something that is new. It's been talked about for many years. What these people did is they made their own research. They realized that access to second trimester is limited. Therefore, patients end up becoming frustrated. They checked and measured the level of frustration of this community. Then what they did is fine. People want to terminate anyway. Remember, back then you used to read in the newspapers and in the news that there were children, there were fetuses that were found in pit toilets. It used to be a fashion. At least every week, 2 or 3 would be reported. But after the introduction of these illegal providers, the story changed a little bit. So now what happened is, we started having people who are not taught of the protocol of how to induce a patient for termination of pregnancy and the dosages that you need based on the gestation of this person. So these people just come in, they put their phone numbers based on knowing that you are frustrated. Remember, these people do not do a door-to-door campaign asking you to come and terminate pregnancy. They just know that somewhere, somehow you are there frustrated and you couldn't get access. So they know you'll get this, you'll take those phone numbers. Actually, who goes to those people? It's you. It's not them who comes to you. So what they do is, the dangerous part of it is that we have so many patients. You'll find the patient being 18 weeks gestation. And because of the booking and all those things and the limited number of patients that we can do at a certain time, you find that we're booking a patient 3 or 2 weeks from the actual date of consultation. And this person doesn't want to wait that long and do not have any other option to utilize any available or alternative service. So what happens is, this person would go there. Now the reason you don't find fetuses in pit toilets is because these fetuses come to us. So you work in casualty, you realize there's a patient who come with ICA, incomplete abortion. The patient was given 20 cytotex, the pills that we use. Because this person is not trained on how many cytotex must you give based on the weeks of this person. They just give 20. The next time patient comes in, the fetus is there. We have what we call uterine rupture. Basically, the patient is bleeding inside and ultimately they die. So we don't want that to happen. So I'm just saying, fella, please, this thing may it be a matter of agency, because this thing it's a very serious issue. Second thing, Mr. Masilela, on the presentation, I just wanted to ask you, let's look into the issue of the contraceptive use. We are struggling with the district in terms of the contraceptive use. If I have 300 patients seeking the termination of pregnancy service in a month, I'm starting to question the primary health care effectiveness in terms of contraceptive use. So what happened is, when I was working in Mafikeng, we used to have what we call the campaigns, Reago di Kolong and all those things. We would go, if there's a gathering like this, I guess sometimes there will be a traditional meeting, okay, community meeting, maybe with the council. We would take advantage of that and ask to be in the agenda and teach the parents about the access to contraception. We would call the nurses, would come in. We would teach the community about it. But those things are dead from the primary health care. That's why I have 300 patients coming to me asking for termination of pregnancy. So the issue now that I identified was that when you look into the structures, how they are categorized, you'll have district, which will mean we'll talk to district hospitals like Buyusuf Dadu, Carltonville. You'll have primary health care, the clinics, and you'll have the regional hospitals like Bularatong Hospital. Now, when you want to come up with a campaign in terms of contraception, they will tell you that you are a member of the regional hospital. So the issue of campaigns and primary health, the contraception, is the primary health care and the district baby and the responsibility. Leave those things. So now, how do we solve the problem? My recommendation would be that in order for us to be, remember, you can have somebody in region or tertiary hospital, but who have strategies or who have ways in which people can get proper access to contraception, but unfortunately, this person cannot infiltrate or go back into the district. So what we can do is, we can form a task team or a committee that will comprise people from tertiary, that will comprise maybe doctors, coordinators, and anyone that can be there. Because then this doesn't say you are from district, you are from regional or wherever. It's just a committee that will go into the clinics and check for the happy hour that they were talking about that is allocated to students. Is it still working? We would want to have the statistics or the logbook, A1, that talks to the happy hour. You don't want these kids to be recorded with a 35-year-old woman who comes for pathogen after every 3 months. We want their own, so that we can compare them from this clinic to another clinic. And at the end of the quarter, we are able to consolidate the whole numbers and say the contraceptive use here has moved with a graph from this to this, or is declining. And then by declining, we'll be able to interrogate the reason why the decline in this particular area. And when we go, if it's the matter of stock or the deliveries are a problem, we'll go to medical depot and ask them, why are you not delivering for these people? If it's a unit manager of the clinic, we'll ask her, don't forget, amongst others, we hired you to make sure that the stock is available. So those things will assist us better. The community is not really getting, that must be addressed as well. Because there isn't one of the obstacles, it's us. I'm a nurse by profession. It's us. I'm not saying them. I'm saying us. To say, hey, only 15 years old, those things. So the committee must look into such attitudes, must look into issues that the stock is available, must look into issues that reporting is done in time, so that we are able to move. Guys, I don't want to waste time. 3 minutes has gone. I have a lot to say, but let me just leave it here.
No, thanks. I had pointed 3 hands. Fortunately, others came, but we were still here. Can we take hands from here to the last row? Okay, there's a hand here, yes. Okay, 1, 2, 3, 4, 5, 6.
Join the queue, please.
Sanbonani.
Yeah, I think I'll queue, everybody a queue. We are pointing hands. Yeah, we were done with this part. We are going to this part. We've pointed 6 hands now. That's fine. She will speak, but I'm just saying, let's allow that process to go that way. Yeah, Baba and Mr. Mato, I've pointed them. They can come and join the queue.
Sanbonani Okulumayo Lady Masalisa from Ward 26 at Davidton.
Ebengikusho mhlambe ukuthi ngoba sifike late sicale ngokulahleka. Okanye kule feedback engiyibona ibhalwe la mhlambe siphendulekile nathi eBarcelona nasemgababa mayelana nekliniki eza kayi1 ngenyanga. Nekliniki encane yaseBarcelona. Okunye mhlambe bengacela kumba party bethu ukuthi kule town planner ezoba iplana ngokukhulisa okanye amakliniki nezibhedlela. Sinesicelo sokuthi labantwana ebeba trainwa igovernment especially lama EPWP ba trainelwa ifirst aid. Siyacela ukuthi nabo babaphe umsebenzi ngiyabonga.
Okay, we've pointed 6 hands. They can all come. Yeah, number 1.
Good afternoon, everyone. Kalibito Kina Buite Policy Teddy from Mohale City, Main Sector Chairperson. Came on 2 occasions. One kia ho echo what the previous speaker spoke about in Tatetlo. It's unfortunate hore as much as the previous speaker and Tatem Rutiwa Murafong. Hore okara the report is actually focusing more on what is happening in the clinics. Relebala hore banaba bunti barona releba tswadi. Relebala role ya rona as parents. And it's important to realize hore ko skolong teacher wa ruta. Teacher o felletsa a imelwa ko gonna motswadi a ba felletsa a nna teacher. We need to take our responsibility. We are unfortunate a community that reacts when things happen. Re tshaba le go di bua, re tshaba go bua nnete. Ke ema fa there's a program ya family semester program. Bontsi ba rona we don't go to school to become parents. Ga o robalana ga go tso cell phone, ga go tso iPhone, go tswa ngwana. And therefore we need to be very frank with our le bana ba rona re ba bolelle nnete. E ke batla go emphasize gape ke gore in some clinics who implement a community or committee members go tsaya sebaka. And therefore I want to encourage all members from the district to for the CSF they fall exactly into what Ntatetlo was saying. In communities we have NGOs that are working, but we are not working in collaboration. It's about time we agree to work together to make sure that this thing is fair. Abortion has an option, reaction.
Dumela. Ka lebitso ke Nthabiseng Manaka, ke tswa ko Ward 96 ko Davidton. Ke botlhoko o re mo re tlo bua ka taba ya di abortion. Ho else a se taba ya abortion fela e le rone ya re tlhokofatsa ka mo site ya Department of Health le tse dingwe tsa di department tsa rona. Re le badudi ke nana hore la kore la rata o ka utlwa re reng. Yes re atla re tisa dillo tsa rona ko lona mara hale re arabe because like on all distance tse dingata batho ba tla batho ba etsa di abortion on all distance report eo ya batho ba le rona ba palla ko etsa abortion le etsang ka yona if batho ba kontle ba gona otla ba etse research ba gone etsisa batho di abortion tse di illegal. Ke na le monyana o le rena sala phone a re over 3 months o ile ko clinicing ba mo jigisitse ba re ka se gone o etsisa abortion. So a sa gone mo etsisa abortion o reng ka ena motho so o re a ye kae o mo rebella tenko lona le di department wa le sa tse research ele le sa tse di stats tse le di report tse le ka ofela la bona re le dirang ka batho ba second semester ka re ha re le monang re le basadi re palla ko ya pele ka re le re tshwere matsogo mara le nya ka ukwa o re dilo tsa rena ke reng ke di reng re a le botsa mara at the end of the day ha le dire nix ke tlo tswa ko lining hanyane re na le balwetsi ba le rene ba ka mo matlung ba kula ba robetse mo dibeteng. Ene benong ha re bone di-caregivers. Di-caregivers, ba scarce too much. Ha ke bua so ke na le mme o le re ba tlile ko nna ba re o kopa di-pampers, ha ana di-pampers, ha ana le dijo, o robetse ko mpetong, o mongwe o na le stroke. Mara di-caregivers ha diyo, batho ba le rona tshwanetse ba tse report eo ba ise back to ko mo clinicing ba berekisanang le lona. So ntho e le rona ke botlhoko ka yona haholo ko rene le safety ya bona di-caregivers tse ha eyo. Re tlaletse ke di-aliens tse dingata, maforeina a mangata, cause o tlo tsamaya o re o ile thusa motho kganthe o ya mo lefung la hao. O ya bona re jwang. So a ke le utlweng dillo tsa rona le emelleng. Le utlweng gore setšhaba se botlhoko sealla. Re dutse le maforeina mo fase ba re bolaya. Lona la dumela re ha ona problem, mara le dutse ka maramatu a lona le ikhielletsa le bone nix ko fase. Mo le rona ke rena re peinelwang mo fase. Ke le moduma e nngwe hape ya clinic. Re sokola ke clinic. Re ile ra bua hangata ko 96 re shota clinic. Clinic e batho ba walker to Crystal Park. Ba batla clinic ba le rena ha bana ditšhelete tsa o kalama. Ba bangwe ba walkela to Davidton ko Squareng. Ha bana ditšhelete tsa o kalama. Mobile clinic ha e fitla e tshwere dipilisi tsa tlhogo le tsa prevention. Ha e kgone ho assista batho ba le rena ba na le di-chronic diseases. So a re bone ena le mmereko mobile clinic. Ene re na le space sa police station e le rena ha e bereke. For rona re bona e catera dikebekwa ene e rentile. So re ko lona how about le rente space seo se rentileng police station e be yona clinic ka baka la rena police station as rona re leng phakati a ke bone e re berekela a e re berekele totally e berekela batho ba le rena ba corrupt fela. So ke bua ke re if ever le tlo bua le re letsa clinic ka kwa 96 no re hopela re at least e be le recreational center whereby batho ba tlo kgona ho exercise or ba kgona ho tlo fola ka pele ka baka la rene hona ba le clinic fela sena recreational center o no tshwana fela o fa molwetsi dipilisi re tshwara o tla fola mara tlamehile ba exercise ene do tso ka fela tlamehile ditso from kolona EPWP e le rene ya bereka ka kwa ke bana ba le rene ha bana experience ha ba tsebe nix ka maphelo le no re batla 18 to 35 mara batho le rene ba na le experience ba tletse ka mo a lenya go ba hira aba kry mebereko le re ba ye kae re tletse mo kaofela le re ye kae rena ke batlo bua hape kwa tsa ke botlhoko ko re ke utlwa botlhoko jena ka gore re na le motho le rene o ile a tlhokofala a shapua ke dikebeko tse le rene re ntse re di le busy re di reporta police station mara ba sa dire nix ka tsona. O tlhokofala ba batlana le clinic gore ba mo ise ko clinicing a bethiwe ka matsogo. So bona re at least ha nka be re na le clinic mo haufinyana motho na ka ba a sa shwa ka nako eo na tla ba a phidile. So antle police station di clinic la re faila la rata re tle mo re tlo senya nako re bolela mara at the end of the day ha le ra arabe. Re na le di-representative tsa rena. Di-representative tsa rena ke di-ward councillor tsa rena le di-PR councillor tsa rena. Mara a ba re direle mmereko, ba re faila. A ba tsebe le di-role tsa bona tsa bo-ward councillor le bo-PR councillor o re ke eng. Ntho ba kgonang ho e dira ba tla ba tlo hira ba hirela di-project fela mara ha ba nyaka tseba gore ne mphakathi o reng ka re dillo tse re di tlisa mmo ne tlamehile ba re di fa bona ba di tlisa kolona ba boe ka feedback mara ba boe ka nix ra hapeletsa re tsamaye distance e tswang kwa golo ko Davidton re tla mo re tlo tlisa dillo tsena ward councillor tlamehile re mo reportela re mmotsa gore ke re shota so tsamaya o ile o re bolellela mara o no tshwana ha dire nix sa ha mmotsa ka project fela. Na re tsebo re wa ile re pateletsa gore re berekisane le diko ward councillors le rena ha di re berekele ward councillor rona na e re berekele le setšhaba se monyake ene report ke itlisa mmo setšhaba ka ofela sa Davidton sa tsebo ra se monyake mara a re kore ne re na le yana meeting the last meeting ne ke na le yana ke mmutsitse ka re le ha o etsa councillor ke eng ha nya go bolela yana o tletse tlo hira batho ba hae ba party setšhaba ka ofela se bolaile ke tlala setšhaba ka ofela se nyako ja wa le re tlisa tsa dikebeko re di re buse Re gopola re le bone hore re tla e dira jwang. Ka lebitso ke Nthabiseng Manaka, Ward 96. Ka leboha.
No, it's fine. Re batla ho kgopela at least re stick to the 3-minute rule. A ke batla ho emisa motho a le busy a bolele. It will not be fair, but please relay 3 minutes each so that kaofela re kgone ho bolela.
Chairperson of the Portfolio Committee, MEC, our beloved MEC for Health, our honorable Health Committee members, maybe stick it to the presentation, because what we heard is the presentation. I'm sorry that the people are emotional. Chair.
Re kopa lebitso ntate.
Chair,
Re kopela le introduce.
the South
Ntate.
African government,
Age ntate.
Chair, the South African government.
Age ntate.
Can I say something? Can you allow me freedom of speech? I am from the structure which has been recapped by our own government, CSF. I am Reverend S.J. Ramoba. I am the oversight portfolio person in the CSF committee. I'll repeat what I wanted to say. Our own government has 3 spheres of government, and of which one of the pillar is the municipality, which is the last sphere. We will ask that maybe you community participation program through your CLOs from various hospitals and clinics, so that they easily reach us as communities. They participate in the local government information dish out, like ward level. Just interact with the departmental network and make sure that you align. When the municipality, the ward councillor go and present his report to the ward, that's where people are. Then maybe you send your CLO to go and interact, and the partner, they also get a slot. Your presentation reflected the financial year 2022-2023. Maybe you give us clarity that when does it start? When is your year? Because the municipality's year is July. And then what is your year as the Department of Health? For us to understand you better that your year has started, then you start using your budget. It reflects in your presentation. The second one, you spoke in terms of lay councillors. And hence, if I understand lay councillor, it's a person like me who has went through the process of counseling. Then that person can go and help our people to counsel them, because I'm a lay person. I'm not a professional. Maybe you outline it as well, that how are you going to deal with lay councillors? Are they going to be community attached or at the hospital level? I'm not lamenting, I'm commending. I started serving Merafom from 2010, and it's too large. When you give us 2 points, while we have got minings, we have got locations, and there are various, from here to Wetela, from here to Kutong, from Kutong to Kokosi, we have got a problem. I think the the previous presentation of saying people will be stressed and they die, then they will be compelled to use the illegal people as well. The last submission on my side, the ownership. There was a time in Carltonville where we from the CSF, the traffic department, the municipality, correctional service, and police, we went through Carltonville town and removed all the illegal posters as department and community structures so that it must become clean. Then we compelled the traffic department and police and say, it's your job, arrest. Instead of for us lamenting here, they must do their job. Then I will go to your department as well. We do not want to meet you when at such gatherings. Come to us. Power to the people. Go down where we are with those health services. We only see caregivers around our streets. We don't see nurses who must come down and start now doing family visit so that our health hazard should be covered. I think I've done justice to you. 3 minutes. Thank you.
Dumelang bagolo. Ke mme Mathabo go CSF committee. Mona ke eme ka bongaka, ke ngaka. E seng ya magwa le se ka nkotla ba health department. Ke ngaka ya setso, ke gogo. Ke nkgono Mathabo. Ke mo ot 26 ke busa ke ntate Mbalus Henry. Jwale mona ke leboha ba health department ka po ditliniki di re amohetse hoba bokoko ba tswile ko matlong ba ne ba tshaba ho ya ka masela a bone ha ba ilo bona kliniki le a bona le lona di AC e thewile haholo hoba bokoko ba ne ba ipata ka difaha ba re ba tshwere ke moya ba sa iko kliniking jwale bokoko ba khona ho ya kliniking ba ntse ba le difaha ba ilo etsa treatment tsa bone re leboha haholo kliniki ha le re tshwere hantle ya o qetela e ke tlang ho yone ke mogutshwanyana haholo ke ena ya abortion kapo ho ntsha dimpa rona bokoko re thulana le mathata hoba batla ho rona ke challenge e re kopanang le yone hoba batho batla ho rona ba re tlo ntsha dimpa nna ke phulusitso bonkgono ke phulusitswe ha re etse ntho tseno re le bonkgono re sebetsa batho hantle ke ka ho nna ke bankang ke re ye kliniki nna bile ke a ba felehetsa le ho ya sepetlele ke ne ke ba felehetsa ho ya leratong ba batlang ho etsa ntho eno ha re ntshe dimpa ke yona ntho e ke tshong ke ne ke re a leboha haholo
Sanibonani. Ukhanyisile okhuluma wase Davidson emhoba 126. So into engithanda ukukhuluma ngayo indaba yeabortion yabantwana nabantu abadala bomama nje abahlala nabo baba. So into yenza ukuthi emhoba abantu benza abortion sisebenzisa iklinikhi e1 yase Barcelona. Usuke endlini uthi yeprevention ufike lapha bafike bakutshela ukuthi injection ayikho. Amapilisi awekho ni date yakho seyindlulile awunayo imali yokuye kunjani kho sekunjani kuyabhadarwa so uzo end up vele so ugcina sewenza isisu ungayimiselanga ukuthi isisu uzosenza abantwana siyabathola vele babafaka emadrainini lapha abantwana besikole because injection abayitholi akuna laba bazothola khona imali siyacela ukuthi igovernment isengezele ama prevention ema-clinic like kithi nje lapha eBarcelona eThwathwa iklinikhi yethu ihlale ingenazo izinto ze-prevention zihlale zingekho. I-mobile clinic iyafika uma uyakhona bakhomba eBarcelona ukuthi hambe eBarcelona. eBarcelona mabefika khona futhi bayakujikisa bathi injection ayikho. So yizi izinto ezenza ukuthi kugcine kutholakala abantwana emadrainini kwenziwa ama-abortion ngendlela wrong. Uyabo because nala uhlala khona isibhedlela asikho sisekudeni. Uzothatha phi imali yokugibela uhambe esibhedlela uthi ukwenza abortion le esemthethweni. Uzoya kulola estradini lothengisa amaphilisi noma ngabe uyamazi uend up kulimala wena ekugcineni. Sicela ukuthi igovernment isibonelele eBarcelona please. Ngiyabonga.
Dumelang. William Gonel wa bua. Program director ke na le complaint tse two le question tse three. Complaint ya ka go hore ke fitlile ke sna notebook ga gona go ngola ntwe tseo department ne di bua ke tla ke di kentse ka hlohong o duma le jwalo mara ke nana gore o la bua le na complaint now ona le di ntwe tse ne re di jwetsuwa mona bo elo wa twata re di tsebe batho ara mseng go at least the documented department ane di distribute to so di ana re fitla gae with evidence re kgona fana ka ntwe tse le re tlile le tsona. And then question tsa ka tse itere question ya pele ke tlo bua mabakeng a di clinic. I think it was on February or before ne re na le IDP ko ma questioning a rona re kopa hore re bane le sepetlele hospital ke nana hore re le le batho ba community re shatuwa ke taba ya hore primary health care ntse re nana hore primary health care ke e sebelletsa ho etsa ditshwanelo tsa hospital hobane o thola hore motho primary health care ke taba ka ska mme aneng a bua monang wa konjegeng mobile clinic ke dipidisi ke ntwa tsa dihloho tshwere ke lino primary health care ha ona mathata a mangata and then hospital a ke di referral and mathata rona go re bongata batho ba le questioning re hloka hore re thole sepetlele se banteng ka re le question hobane clinic e sebedisetswa for dintho tse le horeng ke tsa hospital ha ba kgone lu di emela ho tla le batho ba tšheleng ona mo. So ha o ya clinicing ya mo ke tswang teng o thola hore clinicing eo hona nnetswa etswa petition ya hore ho hlokahala hore ho bane le clinic ka ga le question la rona mare ka ska ke tsholo la re le di bua dintho tseo ha ga IDP ya rona a di etsagale re na le ma counselara a sa understanding municipal system act hore dintho di kopuwa jwang ho kgolomento ga tlise clinic ka ga le question la mne re mele province ebe yone ikutlwang hore isa clinic kae ka ntlo mo as community re tla toito ya re batla clinic ha ona mo re ya re na le di clinic tse ka ga le question tse le horeng service ya teng ntho hore clinic ka 6 ya kwalwa ka pa 4 o'clock where else ha o kula ka 10 o'clock as historically disadvantaged people a rena le tšhelete o palama ya hospital ne re kopa gore clinic tsa rona di ke di considerelo ho bana le service ya di 24 hours again re na le bothata mo ke tswang teng ba di municipal outreaching team ward base batho bana ba sebetsang di clinicing ba tsamayang ba yang le questioning since ba qetela ho nka intake tsa batho ba ka 2015 till now so bane le msebetsi ya batho ba bang ba di intake ba ile go ntlamelo bane le opportunity ya hore re kgone bana le di nurse tse tsamayang strateng ka ska ho nona le ntata na tsho mona kapa bo mme ba ntse ba bua ka di EPWP example la ntwetse. So question ya ka ne le question ya di clinic hore as bahlali community re etsa jwang hore re ikopele hore hospital di be teng ka ga le question la rona hobane di memorandum di ile maspaleng ha e thusi ka next. I'm talking to Gauteng legislator somehow ke nana gore le yona e teng hobane ke bona ba nang le bo rena ba mmuso wa molao ho di masepala e ne le bakeng la clinic. Number 2 question ya ka ya bobedi ke itse di itre question ya ka ya bobedi ko mo ke tswang teng hospital tsa rona ha re fihla re ntsha tšhelete sebokeng hospital o ntsha tšhelete ha ba lata file out of pocket o ntso palame ona le treatment ya ga kgodi eo treatment ya teng o batla bo le hospital beke tse ka ba inthu kgweding ha ona tšhelete ka tlung ha o so cover di basics o blowa ka ba transport o duma transport ha o fihla mo tlamehile hore file e tswe o ntshe 80 ranta or else o tlo dula o fitlhela ka 4 ha ba lo thusa o tla dula ra ka 4 so re batla utlwisisa hore nang tšhelete tse tswang di out of pocket payment tse etsuwang ho di public hospitalities ke tšhelete tse yang kae and re sena next religion. And then hona le issue e mara e buileng ya hore security se caterela for konjekeng entrance we else ka hare security ya seo. Matata a rona ke ona ao so ke bona hore ke 3 minutes fitile metape. Ke batla ho bua. Ne ke batla ho bua metape. Ke ne ke kopela hore tje ka ska ke tswa mo ke tswang teng ke batla ho utlwisisa ka potso ya ka ya bitre dikolong ke bone ho so hosna integration school health program dikolong primary high school re na le bana ba sa boneng hantle ba hlokang dipreli dikolong ha re bone di integration school health program tse thusang bana di ile dikolong kapa batho ba ma teacher amang teacher le nana go ngwana o domo ha hloleha ka speech where else hona le batho ba e lo reng ke di doctor tse understandang oral speech sa ngwana hore ba ka mo thusa ka ngwana wa teng ba mo behe hantle tseleng e jwang re na le bathata a bana ba sa utlwing dikolong a di seibole where else ha o ka go mo romella clinic ba lo mo fa ntho tse le tse kenang ka mono ga kgone ho utlwa re bana le mathata clinic ya rona ha o fihla mo ha ba sa leka hore mosebetsi wa bona o mongata ba tlolla ka hore ba understaff potso tsa ka ne le tsona tse itere ke a lebo.
Dumelang bagolo ka lebitso ke Thapelo Mokone ke tswa ko treatment action campaign ke dula ko Khutsong ke tlo raisa di issue nyana tse ding taba di ngata mo ke lebogela ba Department of Health ha ba tlile but ke tlo leka ho ba mokhutswanyana haholo go summarize se ditletlebo tse ke nang le tsona. So ra leboga ka presentation or report le re fileng yona but our request ke hore we need that report le rona mo go re be le yone as the stakeholders. So it is not good hore balla presentation or report re shebile mole but ha re na le yone le rona it will be much better to understand hore enke e mo reportong eo. And then I just want to raise infrastructure around Western District. Re na le clinic ko Khutsong since e qalwa ka 2015. Till this date, that facility is not operating. And we don't understand the reason behind why that facility is not operating. And that facility cost plus minus 75.8 million. So we don't understand the government aga aga a beautiful facility like that and then e bidula fela yalo. So ya ikeja and it looked campus isumulutso go vandaliziwa and then the community members will be blamed because of vandalization. But a gona next e tla etsuwang if a structure se tshwanang le sele se eme fela se sebetse a gona next e tsagalang. So we need feedback or a report or ho etsahala eng on that structure seo. Because of the report that engage our authorities from local level to sub-district to district level and provincial. MEC or aware ka structure because of aselanta ribua ka son. My request ke hore re kopa a written report hore ho etsahalang ka that facility eo. And then again ko Kagiso ko Mazenville hona le a structure se simolotsweng se agiwa since 2014. that structure ke di-pillars fela tse emelletseng a hona ke foundation fela a hona tswellopele go stopilwe. So ha re latella because rona as TAC we are advocacy group, we are doing monitoring ya rona re batla evidence re batla go go etsagala eng. We find out how the contractor owner a qashitswe in e le motho o sa ikemelang a sena financial, so ona shebeletse tšhelete a patelwang ke government. So the reason e be le gore how can ba hire motho e be yene the main contractor a tlo aga facility e kalo in Kagiso as na financial stable. So we need to know le ka yone that structure seo gore ho etsahala eng ka sona. Please, we need the report tseo in writing. Facility ya ko clinicing e khosa ya ko Kutsong extension 2 e khosa overcrowding to Kutsong South Clinic. E khosa overcrowding to Velfordin Clinic. And then again, a high rate of defaulters, especially on HIV defaulters. High rate ya teng e kodimo haholo. So if a facility in a more than 100 or 200 defaulters, it's a concern. And then our CHW cannot trace those people by defaulting because of the demarcation. So it's a problem. We are requesting for that facility ibulwe operate so that people ba near ba khone go ya facility ba khone go thola treatment ya bone. Again, on a presentation, Mohlompheu o mentioned the contraceptives that are the other contraceptives so tlo bang available kampo di available a ke which is ke vaginal ring le di patch. So I just want to know hore those contraceptives setse di le teng na mo di facility because I ise re di bone rona as TAC because we are doing monitoring in the facilities. So I just want to know in total. But because of 3 minutes in nyane, ke tla fella fo. Ke a leboha.
Dumelang bagolo. Le kae? Bagolo nna ke toba mokhutswane ka lebitso ke Tebogo Koboyankwe ke tswa ko Khutsong belong to a member CSF Community Service Civil Society Forum in Merafong. I stand for review committee. I'm also treatment action campaign member and in Gauteng I'm a provincial main sector rep. So as I'm here leadership, I just want to welcome and also want to thank the leadership of Gauteng Health Portfolio for being here and for allowing us to be a part of this wonderful initiative. Bagolo, now what I want to ask the MEC, this is the questions that I have for MEC. We as TAC, we have got a monitoring tool that we use that is used by Richize, which is saving our lives. It's a project that is hosted by Treatment Action Campaign with 4 other PLHV sectors, which is NAPWA, Sanarela, PWN, and PAC, Positive Action Campaign. Those 5, they make a PLHV sector. So we've got the new community-led monitoring, because previously TAC used to do facility monitoring, which was not involving the community. Right now we are involving the community to be the part of making change within the health facilities. So what TAC or TAC is saying with community-led monitoring, we are monitoring the services through the help of the community, asking questions, relevant questions, and generating data and generating solutions. So we have gathered information from the community, especially in Kutsong South, where we are doing community-led monitoring last month. The youth MEC is complaining that they are not accessing SRHR services in the public healthcare clinics. can you make sure as the MEC that the youth is aware of the happy hour? It cannot be true that the youth is going to the clinic and they don't know what their services they're supposed to access. As TAC, we say, we demand the reports and we demand and we request that those services be accessible to the youth so that they have a friendly, youth-friendly services for all the youth in the clinic so that they're not scared to go because they are told that they are judged by the staff attitude is one of the help that youth is scared clinic because why they want contraceptives. It cannot be true. We say as civil society that must end. The staff attitude is helping that the youth and other community members to not come to the clinics. So those are some of the points that I wanted to say. Those are one of the questions that I had for the MEC. So again, as part of that Steve Clow, I wanted to ask him that in that law, it is a concern what you just presented to us here, that less than women or youth who are less than 15 years, 16 years, 5 of them are also looking to get terminated. So which is it's a concern. 5 is too much. 5 is too much. We cannot leave that. It is really a concern. What is causing that? It's because of the long queues in the clinics. They are told that come tomorrow, come tomorrow. They are not being even referred to hospitals, that there's safe abortion in the hospital. I don't believe that it's been enough marketing has been done or enough it's been done so that the youth can know about it, the women can know about this safe abortions in the hospital. Because they're in the hospital at the maternity ward. We were told by the ops manager that 90% is backyard. Illegal abortions, they go there. 10% only come to the hospital, which is a concern. So we need to do something about it as a community, because I believe we are all public healthcare users as we are here. So I retain something about as community, instead of complaining, let us as in that way, quality health assurance managers. Let us go there and make use that, let our voices be heard. Thank you.
Thank you.
Salwanani. My name is Saluko, in short Sali Kandarira. I'm from CPC, Center for Positive Care. It's an organization that advocates for sex workers. Nizwile ne? Okay. Siyabonga ne presentation. And siyabonga again in the invitation. As a site coordinator wama sex workers, I'm worried about the abortion thing. Why? Because we don't have condoms. As a CPC organization that advocates for sex workers, it's difficult to come with the pamphlets without the condom. You cannot go to a war without a full equipment. So now, when we are dishing up the information, we don't have the condoms to give them to use. So I'm now worried because it seems like we are going to refer so many sex workers for abortion, the reason being the shortage of condoms. So at the sub-district in Merafong, Asna Wama Condom, when we go there every week to ask, they said in the province, we don't have condoms at all. So whether we are going to receive the news that says there is a truck here and a breakdown coming from Cape Town, coming to Gauteng or what. So we need to know what is the shortage, what is the reason for condom shortage, and when is it going to be fixed. Thank you.
Sorry? No, thank you. Will we want to take everybody? Unfortunately, it can't. That's why we pointed hands. And unfortunately, people just keep on coming. Let's get the responses. Then we'll evaluate after the responses if they have not touched what you wanted to ask on. We gave the background. The department responded with 2 or 3, if I may summarize their responses. And we had 13 hands. Actually, we had 15 speakers, which I suppose should be sufficient enough to carry the information that all of us might need to in the hall. The department spoke about strengthening the campaign to create awareness. They also spoke about ensuring collaborative committees to prevent litigations. They also spoke about the rollout to wellness programs to staff. And I'm summarizing this so that if I listen to all the questions raised, it all falls within the 3 responses of the department. But I will allow the department to have the final say in terms of the responses of the 15 speakers that have spoken. MEC?
Okay, thank you very much, Chair. Maybe as I ask the department to come closer and come and respond, I will respond to Ntate Koboyankwe. Okay. Uzwile? Oh, okay, okay. No, thank you very much, Ntate Koboyankwe. As a department, I think we appreciate Mereko Oluirang, and we are also, I think you know that we are working in partnership with yourselves as a stakeholder. And what you are raising is very important. I think in the presentation, Libone Monebari, Negina Deputy Minister launcher your program, and then we also went to one of the clinics, Ekuruleni, Moneba launcher a youth-friendly zone. So it's something that we are taking into consideration because we also had a dialogue with youth. Where the youth were raising their issues, so we're taking that into consideration because with the youth in area, you can't want me omoholo atlomplela ka hager ke batla condom mo tlomplela o monyane so o sentse o robalana and all that. So we really want young nurses ba ileng gore re tlo kopana le bona ha re tswa sekolong re be le youth friendly corner e leng gore we can talk about our challenges as young people. We are taking that into consideration and hence we are creating that space in our facilities. I was trying to check in the West Rand how many do we have, because I think all our clinics are youth friendly, but we want to create that youth friendly zone where a young person wa 14 years o tlo tla ko facility a thole motho o mocha a mo kope condomo a bue a be free ho ka bua anything a batlang ho ibua le ena. So we are really taking that into consideration and we'll make sure that we make those services available in our facilities. Thank you very much. Ms. Mope and the colleagues will respond to other questions. Thank you very much.
Thank you, Chairperson, and thank you to you, MEC. The questions were many, and some of what was said was comments, and others were things that were commending the good work that's done either by communities or the facilities themselves. I'm going to respond to a few of those, and then I will ask Mr. Masilela and the CEOs to also respond to other questions that are related to hospitals. I think first I'd like to acknowledge the comment made by Member Mabale. It is true that as a department you often make this mistake of using acronyms, assuming that everybody understands the same language as us. It is acknowledged, Member Mabale. I think this is something we need to work at. The presentation is there. I think, Mr. Masilela, what we need to do before we leave here is to, in the presentation itself, just explain in detail what the acronyms are, what they stand for, and then we're going to give the presentation to Ms. Ngidi here so that he can make it available.
because one of the things that was requested was that the presentation must be available for everyone. So we'll do that once that is done. And also the contact details of the private providers, Mr. Masilela. I think this is something we need to do because, as Member Babale said, it's well and good to put a name there, but who is this? Where is this person? How do they contact them? Those are valid points that we must take into consideration. Can I respond to the issue related to, I think it's the last but one speaker that spoke about the availability of condoms? Very true. Condoms were not available, not only in Gauteng, in the whole country. The condoms were not there. Why were they were not there? There was a tender that was put in place and the tender expired. When it expired, they knew a service provider that are contracted, not by us, by national. It's a transversal program that is run at national. When they came on board, they had to be taken through quality control, and those processes are very, very long. That is not your problem. It is our problem as people that must provide the service. We have raised this with national, they were aware of it, and they assisted us as Gauteng, I know, to go and look for condoms everywhere they could find them, even from our development partners, to ensure that they are distributed to our facilities. Unfortunately, the quantities were very low. We're not able to reach every facility and distribute all the condoms that are required by each hospital or a clinic. So finally, the process was completed. In the last week or two, the condoms have been trickling in from national. They have been distributing them. The whole process has been completed. The condoms are now available. So what we need to check is to which districts or facilities have not received, so that we make sure that everybody has got what they need. Yes, it is true, if the condoms are not available, we will end up where we are today. We know that, we acknowledge that, but sometimes some of the things are outside of our control. We do something and just not fold our arms, but processes sometimes can be very frustrating. There was a question also about lay councillors. Somebody wanted to know what we are doing about the lay councillors, because these are not professional people. I'm sure all of us know, and I'm sure some of us here are community health workers, because I did see familiar faces that I know. What we have done as the Department of Health is to absorb community health workers as employees of the Department of Health. So what we need to understand is that some of the councillors are working inside the facilities, that is clinics and hospitals, and others are outside the facilities, because we want to also ensure that we address the very issues that came here, that access, we are not visible. So these are the people that must go out to the communities, find them, counsel, test, and refer. Not only for HIV, including non-communicable. It's a broad concept. That's why we no longer call it HIV counseling and testing. It is called now HIV testing services. It includes everything. We also look for males that want to be circumcised. We also refer them. Mothers that are pregnant and have not gone to antenatal clinic, they are referred to the hospital. So they are amongst us. So the department is also in the process of training them and developing the lay counsellors and community health workers that work through the ward-based outreach programs, such that they become professionals, and then they also are able to grow professionally and develop professionally. So that's what we are doing about that. The many questions were related to district health services, that is clinics and hospitals. Why is the clinic not open? Why is this not available? Contraceptives are not available. Some of them were very generic. I think what would help us is for us to specifically be told in which facility in particular is this the problem. Mrs. Leruta was on her way here. I think she had some challenges. She says she's still sorting herself out. If possible, she'll come. And I said, I doubt if you'll find the meeting still on. However, I don't know, Chairperson, if this is acceptable, that perhaps as a department would put in writing all the outstanding questions and submit them to the legislature. I don't know if this is acceptable, so that they are on record when Mrs. Leruta is available to respond to the questions that were not answered here. But the CEOs are here. They will respond to some of the hospital issues that were asked here. Integrated school health program, Fortunately, Mr. Masilela is also responsible for this program. I'll leave it to him to respond to it as to why it is not available, why we are not doing it. Safety of counselors, safety of caregivers, that is a matter that also is on the table at EMC to ensure that the people that are working outside of our facilities are protected and safe. Traditional health practitioners is what was a comment to say that those that come requesting terminations, they take them to the facilities directly. So I'll leave other questions to the colleagues to respond to them. I've got all of them written down. I also wanted to speak to the gentleman from the Treatment Action Campaign. I think I'd like to meet with him outside of this meeting because there are many, many things that he wanted to raise. And we are working with them through Richitsi to get to understand what issues there are in the facilities that they work. They've got the report, they've submitted to us what the state of our facilities are, what they found, and we're working with them to try and sort out. But I'd like to hear other things that he was not able to talk about because of time constraints. Thank you, Chairperson. Can I hand over to Mr. Masilela? Or can I check?
I thought already CEO batla araba pele before
CEOs.
and then whilst the CEOs are still coming, ho na le question e botsitsweng ka Khutsong Clinic, Khutsong South Clinic. Is it no Khutsong South? It's on the other side. King, go extension 5. I get go Khutsong. Yeah. Almost every portfolio committee hari lo present. Portfolio committee lo ana le rona ka hore di clinic tse ahiwang tse sa felang di bulwaneng hona le tse 5 ko Hammanskraal. So re tsere decision ya hore every month we want to open a clinic. But what happened ka e ya ko Khutsong in particular ke hore the service provider o ile ba le mathata a tšhelete, like I think the same situation that we are chasing a clinic, whatever that was being built go Mohale City. So what happened ke hore rona as a department renale an implementing agent bitswang Department of Infrastructure. Ha re age di clinic rona ra di agelwa ha se di fedile di handiwa over ko rona, then be se re kenya staff re kenya di tlhare tsa rona re bona di patient a ke re la itse re hona ne re bula mo Greens Park mo around bo May June. So what happened ke hore DID ile ya itse ha motho o a se tlhola ana le tšhelete ya gore a qetelle clinic eo ebe ba advertiser hape ba hira a new service provider, ba appointile a new service provider e tlo kgonang gore e qetelle clinic. Staff sa clinic se setse se hirilwe, clinic eo ha e tla na le furniture na le everything, so the only thing e tshwantseng e hirwe ke batho ba ba cleanane ntse ke bolella honorable Mabala mo. And then issue ya kokopanong ntate a ka hopola gore ke ntate man ke nahana hore MEC wa infrastructure lile la mona o ile a leka hore a hlalose hore why clinic di ABT e bitswa ke a new technology e mohao o ba usitseng ka nako ele ne se tlo sebedisetswa COVID ka nako ele, but because ha re sa tlhole re na le number ya di COVID patient tse di ka kgonang hore di admitiwe mo ho entswe ntwe ba e bitsang repurposing. So ba tlo e fetola ba etse ba sebedisetse di services tse ding tse leng hore re ntse re na le challenge ya space ka tsona. So ke nana hore re tla follow up le Department of Infrastructure, tla checka le MEC hore ba tlo etsaneng ba iqeteneng yone facility eo so that re kgone hore re sebedise hantle. So ke a leboa, ke tlo kopa di CEO ba responde ko nthong tsa ntwena tsa dipetlele. Thanks.
Baagi ba Gauteng Province dumelang. Nna ke Dr. Rodney Pito, ke CEO ya ko Dr. Yusuf Dadoo Hospital. Mara baagi ba mo Merafong ba ntse bela mo Carltonville. Ke tlo bua ka second trimester CTOP, ne termination of pregnancy. Ka gore ke berekile ko di-district hospital, ke tla batla fela ke leke go tlhalosa gore hobaneng re sa kgone go fa that service. The district hospitals, bongata ba tsone, I only know of one that has specialist, or if one or two. Bo Petha Xhowa le bo Bheki Mlangeni, mara Yusuf Tadu le Carltonville ga rena di-specialist. Yaanong pregnancy e leng gore ha e so fitlhe ko beke ya bo 12, ga e tshwane le pregnancy e above 12, between 13 and 24. Gora gore ga motho wa mosadi a le pregnant a le less than 12 weeks, it's a bit safer with that termination of pregnancy, because the bleeding will not be as severe as a pregnancy ha setse ile gaufi le bo ma 20, 21, 22, 23. Seka mo popelong ke ngwana o felletseng o sa a godile a le closer to a kilogram, go na le placenta kobo ya ngwana e godileng e closer na leng weight e almost above 200 to 300 grams. Yaanong ga le gore e tlo ntshiwa ko sepetlele se tshwana le sa district, me o tla bleeda gagolo a felletse a le ko theater, and then ebe go batlega specialist sa ops and gyne gore se kgone go thusa. So ga rena tsone ko di-district hospital, that is why we're not offering that services. But the good news is tomorrow we are meeting as CEOs, as HR managers, quality assurance managers, go Petha Xhowa Hospital, whereby we are finalizing the generalization of all district hospitals. So this is an idea that I will take to my colleagues that we can discuss to say, you know what, as much as we might not give regional hospital services, but we can try and assist the regional hospital services, because really they are suffocating. So this is one of the ideas that I'll take tomorrow to say, as much as we will be district hospitals, but re tlhoka di-specialists so that re tlo kgona go thusa di-district hospitals. Ke sa itse gore ona le ntho e ke isileng, ga e le gore go na le CEO o leng teng and o batlang go thusa, ke tla mo fa microphone. Tsa di-district ke tsone tseo tse ke di utlwileng le tse ke di buileng. The rest ke di affecta di-clinic. Maybe I can take another question if it's possible.
Through you, Chair. Thank you very much, CEO. You have responded. Ndate Masilela.
Thanks, Chair. Thanks, MC. I'll quickly go over the abbreviations. EVP, let me start with MEC, member of the executive committee. EVP will talk to employee, mainly talk to the employees. Value, right, proposition, it talks to, yes, let me say it's, so,
Responded to the question.
no, I'm responding to the question. So I must leave this.
Okay.
Okay.
Leave it again. Please, let's allow him to answer the questions. It's at the abbreviations. But no bulela, or next time when we make presentations, please make it clear. But also start an EVPA Yorichianako. Please answer the questions as they ask, then.
No, thanks. I will then skip this and we'll put it in the presentation as has been requested initially. On school health, let me start with the school health. I think I'll go back to what Mrs. Mupe has indicated. If we can have a specific school, because what I know in Sidibeng, I think the question came from the participant who was coming from Sidibeng. We do have school health nurses in Sidibeng, in both the 3 sub-districts. And the challenge might be that we're not giving the spectacles as quickly as we should. I think that's the main issue with the spectacles. But the hearing is not that much of a problem, unless you give us a school so that we can also talk to that. Begimlangeni, I think that was missed, but it's part of the 7 hospitals that I've mentioned. On contraception, there was the issue about when are these new methods available, the vaginal ring and the patch, skin patches. We have submitted to national, the department submitted to national the estimates. We are hoping that before the end of this year, we would receive the order because it's a new product and we need to get estimate and send them to the supplier and then, or the manufacturer. Then the manufacturer will supply the whole country and will get, Gauteng will get a part of what they would have, part of our estimation that would have given. There was a question about the adoption, I think, and on termination. A woman who comes to the termination of pregnancy services will be given options before the termination of pregnancy is done. One of the options will be, would you prefer to continue with the pregnancy, especially if it's above 12 weeks? Would you prefer to continue, then have the child adopted, or have this child also going to the system where it will go to care with social development? Now, if the mother, because most of the time, women who come already, who come for termination of pregnancy, have already made up their mind that they don't want to continue with the pregnancy. And as termination of pregnancy providers, you are not allowed to dissuade the women from what decision they've taken. So we don't dissuade them, and we don't even refer them to any other organization. Like you do have church organizations that are promoting the adoption, so we don't do that. We follow what the Act has already indicated to the province. Another question was the budget. When the budget cycle in the Department of Health is from the 1st of April, like this year, 1st of April this year, until the 31st of March next year. Now, municipality is different. I think it's already been indicated that the cycle is different. And then TAs, I don't, then I will leave the others to the MEC. I think I've covered most of these things. Oh, the last one from my side is that we're also promoting, after termination of pregnancy, we do give contraception, or we offer contraception to women, because the purpose of termination of pregnancy is that we increase more contraception and reduce termination of pregnancy. As we expand to the lower category of 12 weeks and down, we'll be training in October. We're training 25 nurses on the termination of pregnancy for first trimester, as we try to expand first trimester. Thanks.
Thank you very much.
Before you conclude, Kenny, he wants to speak.
I wanted to speak to the, I'm not concluding, I'm responding to some of the questions, then I'll hand over to the council. Okay, honale question ene ibua ka, I think it also wako Davidton. Onare makanselara baba fa di tletlebo tsa bone khale ba kopa kliniki, and then honale process e masipala e embaka mo yona. I don't know hore e santse e etsagala because of COVID ya kere dilo tse ngata di le tsa change. Honale IDP process e leng hore e starta ka September mo e leng hore di community ba etsa di needs tsa bone, and le rona as a province we only budget for building a clinic if the need was identified by the community, and then IDP ya bone e bontsha hore ba identify le lefatshe le feng le re ka kgonang go aga kliniki mo lona. Mari, ya ka re na le chairperson a tswa ko Davidton, I think o tla e raise le office ya speaker ya ko Ekurhuleni gore go na le di issues tse e leng gore re di pick up-ile mo stakeholder engagement sa rona sa health. We'll refer those through the chair to the speaker of Ekurhuleni. Then go na le mo ana raise, go na le o mong o raisitseng issue ya police station gore ba kopa police station, and then the issues of police station di tshwana le tse tsa go aga ditleliniki ke responsibility ya Ntate Cela, ke re la mo tseba Ntate Cela. So Ntate Cela o tla aga di police station only if masepala o identify that need ya gore go tlhokega police station or go tlhokega a mobile police station or go tshwantse go agiwe a police station. So tseo le tsone re tla di take through the office of the speaker, so that ba etse sure gore di processes tsa IDP ya ka di tlo starta gona no ba kgona gore ba cover those issues that are raised by the community. And then maybe just to also say ko Reverend Ramuba, we really appreciate the comment, and then the comment re appreciate the comment tse re di kry-ileng, we're taking that into consideration into making sure that we'll also improve. Go na le o mong o na raisitse ntho ya di chronic medication, re na le ntho re bitsang CCMDD mo e leng gore patient is stable for 12 months a tla ko ditleliniking tsa rona, ra kgona gore re go ngwadise o late treatment either we deliver ko gae or we late mo e leng gore go gaufinyana ha o chaisa maybe ko bo clicks yalo. So re tlo kopa gore ha le ile ko ditleliniking le raise those issues so that le kgone gore le kgone go kry chronic medication ya lona. Ke a leboga, ke tla fa councillor chair through you so that a kgone go cover the issues tse ding tse re sa di coverang tse di leng related to municipalities. Thank you.
No, thank you, Chair. Protocol does not dictate that I speak after MEC, but I think there was a question of paying patients. How in our facilities you are assessed in terms of financial affordability, and so you have to provide information that will tell her how khone you can't be made to pay usa khone. So probably if that is a problem, a general problem, kapa a specific problem, maybe we will ask Ntatuana Abua to get in touch with us so that we try and address that problem. Thank you, Chair.
Okay, thank you. That was the responses from the department. And I hope most of the questions raised were responded to. If not, when we adjourn, the departmental staff will still be around if there's anything that you think you need to further clarify. And I take note that the department wanted to further engage with the gentleman from TAC because he had said because of the 3-minute limit, he would have wanted to raise other questions, or there will have been issues that he wanted to take it up with the department. They will still be available after the meeting at adjourned for him to respond, for them to respond to his questions. Otherwise, I must thank all of you for having made time to come here today and be part of this session. If I may quote again from the earlier speaker who spoke, he said, life is not about you, but what happens after you. It was made today. It's not about you, but what happens after you. All what we are doing and saying, our coming together here, it's not necessarily about ourselves, but for those that need the service. So we thank him for that quote, but we, above all, thank yourself, the department, the staff, the MEC, for being part of this meeting. Okay, no, we are advised that everyone can remain seated. Lunch will be served where we are seated, and then forget to return the gadgets that was given to us. We thank you very much. The meeting is adjourned. Thank you.